So the first pathology we're going to discuss are the hemorrhoids. So I would start it with the boring bits, with how physiologically the hemorrhoids come into being, because even as a surgical registrar, I could never understand why you have hemorrhoids, how to see, how to look for them, how to manage them, how do you do surgeries for them. It's one of the surgeries whenever I'm doing a hemorrhoidectomy, I can never satisfy, I can never please the surgeons, because everyone has got their own ways. And I kind of go back to the basics, try to understand how the hemorrhoids come into being, and that's really changed a lot in my surgical practice as well. That gives you kind of an idea of how to deal with the hemorrhoids. They are defined as abnormal swelling or enlargement of the anal vascular cushions. Now, I'd never heard of this term before, the anal vascular cushions, but we do have these vessel-like cushions in the anal canal, extending from inside the anal canal all the way to the outside as well. And they sort of consider them as a cushions or as a adjunct to your internal anal sphincters or external anal sphincter as well, because that's what they basically do. They've got a physiological function, but obviously they're not made of muscles like the sphincters. They're obviously vascular cushions, so they're not as strengthened. They're quite flexible. They get filled with bloods as well. Sometimes they don't have any blood in them as well. So with more constipation, you've got more straining, more blood pouring into them, enlargement of those anal vascular cushions, and that gives you the hemorrhoids. So if they've already physiologically present and there's enlargement of that, then you can see what the hemorrhoids are basically, and we'll get to that as well. They usually act to assist the anal sphincter in maintenance continence, and there are three, usually around 3, 7, and 11 o'clock positions. So if you've got those swellings in the 3 o'clock, 7 o'clock, or 11 o'clock position, we'll talk about in a second, then it's most likely an external hemorrhoid. You can literally see them without any rectal examination as well. Just open inspection, you see those swellings around that, then it's usually the hemorrhoids. So let's say you put someone in lithotomy position with their legs up. So the top part, just imagine that you're looking at the clock rather than the anus, and then the 12 o'clock position would be the position between anus or the vagina or anus or the scrotum. That's the 12 o'clock, and then their left leg, which you're looking from the bottom end, on your right side would be the 3 o'clock, and then the bottom bit would be 6 o'clock, and then 9 o'clock, and then just like the clock. So that's where the normal physiological hemorrhoids are: 3, 7, 11. Most likely they cause the bleeding and problem, and they require surgery as well. Internal hemorrhoids usually only cause bleeding. They don't cause any pains or anything, so you don't have to necessarily treat them as well, unless they become troublesome or they come out. When these cushions become abnormally enlarged, they can cause symptoms, become pathological. They are termed hemorrhoids. This is the classification or the degrees of hemorrhoids. First degree are they remain in the rectum. Second degree, they prolapse through the anus on defecation, but they spontaneously resolve. So patient strains while defecating, and then after that, when they palpate or when they clean themselves up with the napkin or tissue roll, they don't see anything. So that's grade 2. If they have to manually reduce them, that's grade 3. Mostly grade 3 and grade 4 require surgical interventions. Grade 1 and 2 usually they only cause on and off bleeding. You can either leave them or you may have to give something for that as well. But third and fourth degree prolapse are the ones that you kind of have to refer for surgical interventions. Fourth degree becomes persistently prolapsed or thrombosed, and they never go back in. That's the fourth degree hemorrhoids. They're also called prolapsed hemorrhoids. The main risk factors are, I can never stress this enough, constipation, increasing age, raised intra-abdominal pressure with the chronic cough, pregnancy, ascites. They do have those risk factors, but the chronic constipation and straining is the number one risk factor of forming hemorrhoids. Other less common risk factors include pelvic or abdominal masses. Obviously, they have a pressure effect, venous congestions, and those venous congestions come into the vascular cushions as well. And family history, cardiac failures, and portal hypertension. Portal hypertension would cause rectal varices and all the way across coming down into the vascular cushions. That's how you get hemorrhoids as well. And usually someone with a chronic liver disease who has esophageal varices for the upper GI bleed, they usually have rectal varices. Their hemorrhoids are quite impressive. They're really large, and you don't want to just go into rush into the surgical option unless they cause problems. Clinical features, they usually present with the painless, bright red rectal bleeding. Now, there's only one differential for only the bleeding that's coming from the anal canal, and that is painless, is the hemorrhoids, unless proven otherwise. Now, why are they painless? Why don't the hemorrhoids usually cause pain? Again, back to the basics, anal vascular cushions. Just like I said, they only have vessels in them, so they won't cause any bleeding. They don't have any nerves in them, they won't have anything else. And obviously, the vascular cushions, so they only cause painless, bright red bleeding. So the pain is the differentiating feature between hemorrhoids and many other pathologies as well. Commonly after defecation, obviously some of the vessels burst while straining as well, and you get those kind of red spots or bleeding on the tissue roll or on the side of the stools basically. Imagine a container that filled with liquid, and on the inside, let's say about this. So if it's a container with the feces inside, and this lining has some blood in it, so when you pour it, the bleeding usually lines on the side of that. So while if the bleeding is coming from way higher up, let's say the rectum or the sigmoid colon or descending colon, the stools have a time to pass, and obviously with the peristalsis motion of the large bowels, it usually gets mixed. So inflammatory bowel disease, diverticular bleeds, the bleeding is usually mixed with stools, while when it's coming from the anal canal, it's literally like a toothpaste. It's coming from the side, and it's the bleeding's only stuck on the outside. That's kind of the appearance that gives you the diagnosis as well. One thing that I've noticed apart from the from the lower GI bleeds and the hemorrhoids is it's quite impressive. Even if you have a small bleed, the patient that comes usually will have a picture. So always take a look at the picture, whether there's a fresh bleed or whether there's a black tarry stool. And the patient shows you picture, they're quite embarrassed. I'll be totally sharing my insights. They're quite embarrassed in showing their stools. So what they do is they flush the stool, but they're still sitting on the toilet. So what you see is an empty flush with the white, obviously water clear transparent with some blood mixed into it. That usually kind of gives you the rough idea that they have bled after the defecation as well. That's hemorrhoids for you, and that's very, very common. A patient comes to you, shows you their pictures on the mobile phone of their toilet seat and only showing red color mixed with the water. That's usually after the defecation because they've already flushed their feces. So that gives you an idea that it's hemorrhoids as well. 9 out of 10, it's usually hemorrhoids. Other symptoms would include pruritus due to chronic mucus discharge and irritation, rectal fullness or anal lump, and swelling as well. Sometimes the large hemorrhoids, they do cause rectal fullness, but if someone comes with a rectal fullness, always make sure you do the PR examination to rule out any solitary rectal ulcers or rectal cancer as well. And obviously it can cause impaired continence and to mucus discharge because just like we talked about in the physiology that these are vascular cushions and they help with the continence. So what happens when you lose them? Obviously, if there is a pathology of them, you lose some part of the continence as well. Large prolapsed hemorrhoids can thrombose. Obviously, those blood vessels, the venous blood is not going anywhere, so it just becomes clotted. And when it becomes clotted, that's when you get painful. So if someone's got a hemorrhoid and that hemorrhoid has become painful, always try to palpate the hemorrhoid. What happens is, if that palpable thrombosed hemorrhoid, quite a large one, is really tender, it's because of the thrombosed hemorrhoid. But what happens in the background is sometimes people can have anal fissure just between those two hemorrhoids. So if you can't examine properly, if you don't examine properly, you miss the diagnosis of anal fissure hiding just underneath those hemorrhoids. So I can't stress enough just to inspect on the outside even before doing any PR examination. But I've seen most juniors do it. They've already got Optilube on their finger even before the patient pops their pants down. So it's like the aim in the life is just to put the finger in when it's not. When you just do the examination on the outside, it gives you plenty of diagnosis, just like the hemorrhoids and the anal fissure as well. And thrombosed hemorrhoid, people come to the emergency department because they can't even sit. Examination will be normal unless the hemorrhoids have prolapsed. Just like I said, if someone tells you they can feel the hemorrhoids on the inside, they can't. It's you can't feel the hemorrhoids on the inside because again these are just blood vessels between your finger and the patient's muscles. They're just gonna get collapsed. You can only see them if they're already outside or if you do the proctoscopy. Thrombosed prolapsed hemorrhoid will present as a purple-blue edematous tense and tender perineal mass, and we'll look at the few images as well. This is the classical 3 o'clock, 7 o'clock, and 11 o'clock position. Sorry about the spellings. So these ones, if you look at the anus, I would look at it like a clock. So this one is in lithotomy position. So the patient's legs would be, this would be the left leg, and this is where the right leg would be. And if you imagine, let's say this is a male, this is where the testicles would be. This is the 12 o'clock, this is 3 o'clock, this is 6 o'clock, this is 9 o'clock. If you put the patient in the left lateral position, what happens is on the top, if you look at like this is going to be obviously the 9 o'clock, 12 o'clock, 3 o'clock, and 6 o'clock. But you have to kind of orientate and examine a few times just to sort of give you that orientation and then see which position are the hemorrhoids. So this is the anal mucosa that's coming from the inside, that's obviously red colored, and this is from the outside, and you can see this junction as well. And if you see these boggy hemorrhoidal tissues, all of that from the internal to the external, that's the hemorrhoid. So this one is at 3 o'clock roughly, this one is at 7 o'clock, and this one is around 10 o'clock as well. So you can see how these are internal external hemorrhoids, the classical ones where the anal cushions from the inside are coming down and they're all engorged into this massive hemorrhoid. So this one, if you can reduce it, because you can obviously see it, so it's at least grade 3, it's prolapsed, but if you can manually reduce it, that's grade 3. If you can't reduce it, that would be grade 4. These are a few more. This is on the flexible sigmoidoscopy from the inside. How would they look? These are all the anal vascular cushions, all of the hemorrhoids. These are multiple hemorrhoids. You can see these are not just at 3, 7, or 11 classical positions. They are, let's say, 1 o'clock, 3 o'clock, 4 or 5 o'clock, 7, 9 o'clock as well. So you can, it's not necessarily that you would have 3, 7, 11, but that's the classical presentation. And these ones are thrombosed hemorrhoid, where you can see these two are just hemorrhoids. They are swollen obviously, but not causing much, while this one is a large prolapsed hemorrhoid which is thrombosed. You can see from the blackish bluish spots, and there is some gangrene, some necrosis going on as well. So this would cause infection and the pain. And this obviously, this infection would require surgical drainage or antibiotics as well. Differentials, always do the PR examination. My senior professor would always say there is only 2 contraindications to the colorectal examination. One, you don't have a finger, and 2, they don't have a bottom. So this just stresses you how much important it is to just do the PR examination. What I would add to this is, with my humble experience, is if someone's got anal fissure, if they come with painful PR bleeding, if they say, I'm having pain at the back passage when I pass stool, and you see a fissure on the outside, please don't do rectal examination. That's the only third exception I can add. You can always ask the patient to come back in a few weeks' time. Once the fissure is resolved, you can always order another scope. You can always do another examination, PR examination or proctoscopy later on once the fissure is settled, to make sure you don't miss any other diagnosis. But in the acute settings, if someone's got a fissure, you don't do rectal examination. But apart from that, do it for all the ruling out of malignancies, bowel diseases, diverticular disease as well. Other perianal differentials to consider: external piles, fissure, perianal abscess, perianal fistulas, sentinel piles. We call them piles when they are not. They look like piles, but they are just skin tags. This is body's natural mechanism to kind of overgrow and cover the fissures. When the fissure can't heal, the body tries to grow the skin from the outside and tries to cover it with that, like this. Those are called sentinel piles. Proctoscopy is typically performed to confirm the diagnosis. If you can do PR, you can do proctoscopy. That's my kind of paradigm. If you're in a primary care setting, put the proctoscope in. It gives you an idea if you're dealing with any sinister pathologies, or just to confirm the diagnosis of hemorrhoids as well. Any significant or prolonged bleeding or signs of edema should warrant a full blood count and a clotting screen. A colonoscopy is often advised, especially if complicated hemorrhoids, because if you get hemorrhoids and they are complicated, quite a large thrombosed hemorrhoids, just like chronic liver disease, patients with you're like, okay, the patient had hemorrhoids for 10 years, but they have gotten so much worse in the past few months, so something is going on. I would do colonoscopy at this point, and 9 out of 10, or at least 8 out of 10, you see a pelvic mass or a large colorectal malignancy that's causing those pressure effects and blocking the venous drainage. That's why your hemorrhoids are getting complicated as well. So rule out any concurrent anorectal pathologies, pelvic masses before any surgical intervention for hemorrhoids is started, because you can treat the hemorrhoids with the surgery. If you miss the cause why the patient is having those hemorrhoids, it's just it's going to be horrible. So nearly all hemorrhoids can be managed conservatively, because again, if you go back to physiology, I can't stress this enough. It's just normal anal vascular cushions, and if they are not causing any problems, you don't have to necessarily remove them, because they are part of your body. They're a healthy part of the body. They have a function. They are performing it well. If they're causing any symptoms, I would manage them conservatively. If it's causing pain, painkillers. If it's due to constipation, treat constipation. If they're causing bleeding, reassure the patient. The bleeding usually stops. Previously, there was a role of flavonoid, but recent studies showed Teflon or any flavonoids usually doesn't help. Stevias, those sweeteners, herbal teas, they usually don't help. Ensure to provide lifestyle advice, daily fiber intake, topical analgesia if they are thrombosed and causing pain, lignocaine gel. I would advise that freezing or cold packs or ice packs, or in my experience, the frozen peas, they do help as well. So have a pack of frozen peas and sit on it. You can sit comfortably, and it causes less swelling and it soothes those nerves as well. So that's another trick as well. Avoid oral opioid analgesia, because obviously you get codeine for the pain, but then causes more constipation, more straining, more hemorrhoids, more thrombosis. So you kind of have to find a balance between the opioid analgesia and the laxatives as well. For thrombosed hemorrhoids, sitting on ice packs, yes. Topical lignocaine gels, topical anesthesias, they usually tend to help a lot. Symptomatic first and second degree hemorrhoids, and they can be treated with rubber band ligation. It's a very simple procedure. I don't know why my department usually does it as a day case surgery rather than the clinics, but I'm pretty sure that previous settings that where I've worked, put the proctoscope in. If you've got a suction machine and a rubber band gun, you just put the rubber band ligation and that's it. Solves the problem. But that kind of gives you an idea how quick of a procedure it is and how helpful it is for grade 1 and 2 hemorrhoids. Grade 3 and 4, you usually have to perform a formal hemorrhoidectomy where you remove the fleshy hemorrhoidal tissue. But grade 1 and 2 hemorrhoids, if they are asymptomatic, manage conservatively. If they are symptomatic, you can do rubber band ligation. Anal fissures. Anal fissure is a tear of the mucosal lining of the anal canal, most commonly due to trauma from the defecation of hard stool. Anal fissures are usually caused by inflammation or trauma to the anal canal. The risk factors are again constipation, dehydration, and inflammatory bowel disease. Let me go back to a few slides earlier and let me give you a bit of physiology again as well, and why does this pathology hurt. If you look at this hemorrhoid picture, you see this kind of a line between this pinkish color and this bright red color. This line, this Z line, is basically embryologically where the gut ends and the skin starts. Below this line, what I mean by below is just outside this line towards the skin has a lot of nerve fibers. That's where the pain occurs. And above this line, this mucosa, the anal canal, the rectum and everything, you can't feel pain with that because there's only stretched receptors in the GI tract. As long as these are not massively stretched, you don't get pain in this region. That's why the hemorrhoids are usually painless, because they're coming from this part. The anal vascular cushions, they're coming from the anal canal, so they're not really painful, while the anal fissure occurs just around here, and that's on the skin. That's why it's very painful. Anal fissure pain can cause horrendous pain. It so much affects the quality of life that it's astonishing, and that's why you get quite a lot of pain with the fissures. Yes. So classified according to its duration. If it's more than 6 weeks, it's chronic. If it's less than 6 weeks, it's acute. Acute is usually without any cause, and it should resolve with the creams and conservative management. If it's more than 6 weeks, you have to probe further in what's causing that, basically. If it's an underlying disease, if it's an inflammatory bowel disease, Crohn's disease. So Crohn's disease can happen all the way. We'll get to that later on as well. It can happen all the way from mouth to the anal canal. So it can present various gastrointestinal problems, and persistent anal fissure is one of them as well. That's where the anal fissure happens. And if you see that kind of cracked line, below this, any pathology would be painful. Above that, any pathology like these hemorrhoids shouldn't be painful. That's how the anal fissure looks. You can see this tear in the anal mucosa, and obviously this gets irritated with the sweat, with the bacteria from the skin, and also the fecal content. So that's very painful. Most common presenting features is intense pain post-defecation, which can last several hours. And obviously with that pain, the patient drinks less water, eats less, becomes more dehydrated, becomes more constipated. So it's kind of increases that vicious cycle of constipation causing anal fissure pain causing constipation, and it's a very vicious cycle to read. And itching, palpable. Sometimes features are palpable. I wouldn't touch them, to be honest. Digital rectal examination, I would never do it for anal fissures. You can always do it later on. Posterior midline usually happens in the posterior midline. What I mean by that is 6 o'clock position, just like that, if you consider that as the top. And if the patient refuses digital rectal examination, just to confirm the diagnosis, you sometimes have to anesthetize the patient. That's called examination under anesthesia as well. So it can be very, very painful. Fissures in the anal canal can then be identified using proctoscopy, but only once the patient is anesthetized with the general anesthesia, and then you can treat that at the same time as well. Differentials would be hemorrhoids, Crohn's, ulcerative colitis, and obviously squamous cell carcinoma of anus can present as an anal fissure as well. Multiple fissures or anteriorly located fissures, you shouldn't have multiple fissures at all, or something's going on. Or if there are interior, that's where the pathology is coming from some other place as well. Usually medical management is enough. The majority of the patients would not require surgery. Usually treat the constipation and apply some GTN cream 2% and the lignocaine gel diltiazem cream, which is a calcium channel blocker. It increases the blood flow to that fissure area and promotes the healing as well. And give laxatives, plenty of water, plenty of laxatives. It should resolve. 99% of the time would resolve. If it's not resolving, it's not your management. There is an underlying pathology like Crohn's disease, ulcerative colitis, or multiple other things that you need to rule out. Diltiazem, GTN, just like we talked about, relaxing the internal anal sphincter, and you have to apply on the inside of the anal canal as well. Pilonidal abscess. Basically, the main pathology is the pilonidal sinus. How it develops physiologically is the answer to all of your questions. How it develops is usually young males who have coarse body hairs, thick body hairs. The body hair, you sometimes develop a small infection, folliculitis. It kind of makes that small cavity. That cavity gets blocked with the hair, and that cavity becomes infected, just like we talked about in the gallbladder, just like we talked about the salidinitis, which is the inflammation of the salivary gland. Anywhere in the body where there is a blockage, proximal to that blockage, infection happens. So that small sinus, which is a blind track of the hair, this hair gets stuck in it and the cavity gets infected. That's how you get the pilonidal abscess. So the sinus forms and then sinus gets blocked. You get an abscess. The abscess pops. The cavity is still there. It gets blocked again. You get another abscess. So it's kind of a vicious cycle between pilonidal sinus and abscess formation, and then it just never goes away. Some of the studies show, to be honest, that the recurrence rate of pilonidal sinus, even after you remove everything, up to the 3 years is 50%. So all your patients who had the procedures, half of them are bound to come back after the 3 years time. That's how bad of a recurrence rate of this disease is. It just never goes away. Classically, it is associated with people who sit for prolonged periods, lorry drivers and office workers. Obviously, their butt cheeks are like opposed to each other, and there's pressure effect of hair going into those cavities. But obviously, with obesity, intense exercises, many other work-related fields, you can still get those pilonidal abscesses. That's kind of physiology of how it happens. Typically happens in older males around, younger males around 16 to 30. Very rarely happens over 40 years. That's the skin. That's your blind hanging tract. And this is the kind of pilonidal cavity where the abscess formation happens. And that's the strand of hair that gets stuck inside, and that causes the inflammation. And it usually happens on the nasal cleft, obviously, because the butt cheeks are opposed to each other. That's the pilonidal sinus, and obviously when it gets infected, it's going to look just like this. So that's the abscess. This one's the sinus, and this is how an abscess would form. And you can see it kind of wants to pop out. So the treatment for this would be that you need to make a nick across and do the incision and drainage of the pilonidal abscess. I absolutely encourage draining of pilonidal abscess in the primary settings. I used to do them when I was working in in the primary care settings about 8 years ago. I would do them all the time, unless you think that you need surgical drainage under general anesthesia. A pilonidal abscess can form where the sinus becomes blocked and infected, and there is a fluctuant and tender mass. If it's fluctuant, there's fluid inside that needs to come out. And it's usually a clinical diagnosis, and investigations are seldom needed. Treatment would require oral antibiotics, surgical incision and drainage, and just like we talked about, the recurrence rates are up to 50% in 3 years. There's some recent advancements with laser procedures. Some people do endoscopic procedures, flap procedures. As long as the sinus is still there, as long as the risk factor of being young, coarse hair, those occupational hazards, it's always there. The recurrence rates is still high.